bony bulge, and the anterior inferior to it, the facial nerve. Behind the mastoid dissected, the cells are removed. You see this blue structure, which is the sinus, the lateral sinus or sigmoid sinus. Above here, the tegment tympani, tegment mastoide, separates the medial area mastoid from the medial cranial fossa. So you know that the patient with cholecystoma may have intracranial complication due to erosion of these bony partitions. This is the normal tympanic membrane. Which ear here? You can tell it is the right one. How can I tell? By the cone of light is under the inferior, so I know the directions. Also, this dark area, the meatus is deeper anteriorly, so that I can tell that the anterior is posterior. Also, the annulus malleus is usually downward and is slightly backward, so I know again the directions. I can tell it is the right ear. The landmarks, we have the burst density stents, we have the cone of light, we have the umbo, we have the annulus malleus. If I go with it, I reach the lateral process of the malleus, and above it, I see the pars flaccid. We have two folds, one anterior, one posterior, the malleolar folds. So the color is purely white. In other conditions, maybe yellow, blue. We'll come to this. The assessment of hearing. This tuning fork tests, you know them, Turner and Weber. They are only to categorize the hearing loss into conductor and sensorineural. You know how to do the tests, how to interpret them. If the innate test is negative, the bone conduction is more, so the patient may have problem with external ear, which is easily excluded by examining the ear. You see the ear, you see the tympanic membrane, then the problem is not in the external ear. It is in the middle ear by this tuning fork test. So you think of tympanic membrane problem, middle ear problem, sticky problem, stapes, ossicles, I mean. In sensorineural hearing loss, the patient will have hearing problem in this ear, so the DNA will be similar to the normal people, positive. It is better than here, although it's very weak here, but it's similar to normal people. And then, so it is a RNA positive. And then when you do the Weber test, it will go to the healthy side. We do this radiological test before operation, before fitting hearing aid. So we have different types of audiograms. One is here, the conductive hearing loss. You can add this by the normal bone curve, and the air curve is down with this airborne gap around 50 decibels. So you can enumerate a lot of causes for this. Here again, the airborne gap and the tympanogram. Tympanogram shows the high compliance is above normal. So it indicates that there is a circular disconnection. It's called AD type. So you do more than one test in audiology. This is the battery of tests. Why we do battery of tests? Because we need to improve the sensitivity of the battery. Because if you do one test, you may not be able to diagnose the cause. So to be more specific and more sensitive, you do this in the form of battery. Here an example of conduction loss, the otosclerosis. Patient with otosclerosis have conduction loss, tinnitus, maybe they have what's called paracusis. You know paracusis? Paracusis is abnormal hearing sensation. So the patient will complain of hearing better in noise. This means that we call it paracusis Willesi. So you have this patient, usually more females, and she has unilateral bilateral conductive loss. The tympanic membrane is normal, or there is red color behind tympanic membrane indicating active disease. We call it Schwartz's sign. And when you confirm it by tympanogram, you will see the small curve, AS curve, indicating circular or stapes fixation. We are in the audiology part. We need to assess hearing by electrophysiology. serological test, especially in difficult test patients, patient with mentally retarded patients, a young child, malingerer, comatose patient. We can do this, or doing surgery. We can monitor the hearing by this electrophysiological test, the ABR. You know, the E. coli, the nuclei that generate these waves. We use this test for two main reasons. One is the threshold of hearing in this group of difficult to test patients.
Delay.
Another, yes, neurodiagnosis for the acoustic neuroma or retrocochlear lesions. So in the retrocochlear lesions, you see the delay, interoral latency difference between the right and left ear. So we do the two ears and we see if there's significant difference between or delay between the two ears. Then we suspect that this retrocochlear pathology may be tumor, so we send patient for MRI with contrast. Dr. May would like you to leave the course with some knowledge about the CT of the temporal bone. So I put this, this is the cut in which you see at the level of the meatus here, the cochlea is in front, the vestibule is here, the lateral canal is here, and then you see the lateral canal is above the facial nerve. Facial nerve is here. If you imagine the facial nerve is running like this, above it, the lateral canal. So you see the part of it, of the facial nerve, and it goes below the lateral canal. Here in the middle ear, you see the ossicles, malleus and the incus and their articulation, go to medial joint. Here the hair cells, you are with air inside, with the bony septum, very clear. But in case of acute mastitis, there will be ossification, maybe disruption of the septa. So you see an abscess cavity, maybe erosion of the cortex, maybe you see this. If we would like you to remember some disease of the external ear, so we have cyanotitis, the localized form, pharynculosis of the external ear, and also the diffuse form in swimmers. They have this very tender ear few days after swimming due to pseudomonas infection, due to staphylococcal infection, due to infection in one of the hair follicles. This is another condition, the automycosis, fungal infection. Again, very common swimmers, due to wetness in the deep meatus, wet skin, is a good medium for fungus. Here you see the black dots indicating fungal growth, especially Aspergillus niger.
Newspaper.
Huh?
Wet newspaper.
Yes, wet newspaper-like material, you need to remove it, and then the hearing will improve, and then you apply antifungal, topical antifungal drops. Cyanotitis is a common condition, but one category is serious. The malignant type, the necrotizing type. It's a sort of skull business myelitis. A diabetic patient may get this infection. It's not at any case of cyanotitis, but they are more than the usual case. So there is infection of the bone, especially in the floor of the meatus, between the bone and the cartilage. There's evidence of bone infection, with granulation tissue formation, very tender ear, swollen ear. You cannot see the depth of the canal. There's some discharge. The patient has severe pain. It does not improve on the usual antibiotics. There's a pseudomonal infection. You need to give first to control the diabetes, second to give anti-pseudomonal antibiotics for sufficient time, maybe up to 6 weeks. Maybe quinolones, glycosides, or third generation cephalosporin. And they monitor the treatment by the bone scan. So this will tell you that the bone is still infected. You can monitor until there is clear up of this bone infection. Then you are successful to treat the patient. Otherwise, it may recur again. It may come with facial palsy. It may kill the patient if not treated. Middle ear problem, one condition, traumatic perforation, slap in the ear, explosion will rupture the tuberosity. As you see, the perforation is fresh one. So you see irregular edges, sharp edges, irregular shape, some evidence of bleeding, but the middle ear is normal. There's no evidence of infection because it's very thin, even white bone you see. Indicating that because it's very thin, not inflamed. Thick mucosa will be red, and you will not see the bone as clear as this. But you can see fresh middle ear. With this here, still perforation, this is the antimanias that are processed to the arriving again. And then you see the perforation in the middle ear, very normal. So you can differentiate between traumatic and pathological perforation.
It's the time.
Eh?
Traumatic.
Traumatic perforation. And then we come to the second category of disease in the middle ear, inflammatory problem. Middle ear, the main problem with that is inflammatory problem. So we have some types of test media, acute and the chronic. This is the acute type. A child, white child, because of the second tube, because of other risk factors in the community and in the child itself. So we see this condition in children. They have common cold, and then they develop severe pain in the ear, with fever, crying, rubbing in the ear, pulling in the ear, and they examine them. You see the infection, inflammation, different stages. You can see it in the clinic, any stage, very early or very late. Even so, we say it is in the stages. You have premium stage, you mean cartoon appearance, like here, with congestion along the helmarias and the periphery, and also the burst flaccid. Hyperemic stage, then suppuration stage, then pus under tension and perforation. You can see the child in any one of these stages. How to abort the attack by antibiotic. Anticongestant to the nose, analgesic for the fever and pain, it may resolve. If there is pus under tension, you may need to incise. Incision of the membrane is called myringotomy, and you don't need to fix a tube in this case. But tube, if you need in this condition, the chronic type of dysmedia, the dysmedia diffusion. So there is pain, no pain here. The child may have history of pain and the current dysmedia, acute type, but now he doesn't have pain, he has only hearing loss. This has been noticed at home, at school, and they have hearing loss without pain. They may have other symptoms, of course, but like something in the ear, something moving in the ear, some tinnitus, sometimes they say they have some dizziness, but this is not the case, the usual. The usual is to have a child very normal with hearing loss and without any pain and other complaints. If they are old enough, they may express, you can ask him about the problem, what you feel in your ear, and he may tell. But here, it's only the hearing loss that is noticed by others, the school teacher and the parents at home. So when you examine, you see evidence of fluid. Evidence of fluid, the color is not the pearl white, it is yellowish, bluish. And then you see airflow level, you see bubbles. So there's evidence of fusion, fusion. You confirm by the tympanogram. If it is not very, depending on the time frame, we can wait for 3 months. If there is resolution, okay. If not, we go for myringotomy and fixation of a tube. This tube will bypass the obstruction of the second tube. Because the patient, usually we tell that the second tube is a problem here. Maybe he has adenoids in the esophagus. So you need to do the myringotomy and fix the tube. Another type of dysmedia is a CSOM. We have two types. One safe, one unsafe. One cholecystomatous, one non-cholecystomatous. One mucosal, like here, and one bone erosive. Okay? So this is the mucosal type. The patient has perforation in the ear of variable size, small, medium, large, subtotal. It is we call it central perforation. It does not go to the bone, does not reach the bone, but you can tell there is all around there is edge or there is a remnant of pars tensa. So it is a central perforation, safe perforation. There is no evidence of invasion of the middle ear by skin. There is no white thing in the middle ear. There is no accumulation of keratin. So indicate that it is mucosal type. The discharge is usually intermittent. So when common cold comes over, this water gets inside the ear, the patient starts to have discharge in the ear. So the discharge is usually intermittent, mucopurulent with the pathogens, if it is through the common cold. But if it is through the perforation itself from outside, it could be an organism, a skin organism, gram-negative again. If there's active infection, you treat them with antibiotics. Care for the ear and antibiotics, and until the infection clears. And then you think, you tell the patient that he needs laryngoplasty or tympanoplasty operation to close the perforation, to improve the hearing, to stop the current infection, and to keep the ear healthy, because leaving the ear open like this to the air, gradually there is more and more hearing loss with every attack of infection.
Hearing loss is something.
Hearing loss is conductive. It is not total. You will do the pure tone. You'll find an airborne gap depending on the site of the perforation, the size of the perforation, the condition of the middle ear and the ossicle. So you have to plan your surgery based on this pure tone. If there is a small airborne gap, it is only for laryngoplasty. If there is a big airborne gap, you expect that there is a ossicular problem. So you prepare yourself for this ossiculoplasty or what's called tympanoplasty, including ossiculoplasty. So ossiculoplasty is a part of the tympanoplasty. So if I can make an equation, is tympanoplasty equal laryngoplasty plus ossiculoplasty. Tympanoplasty يساوي laryngoplasty plus ossiculoplasty. The other type of CSOM is the cholesteatomatous type. The cholestoma is a skin sac growing in the middle ear and mastoid. It originates from the tympanic membrane and the skin of the external meatus. So it originates from the skin of the external meatus. It grows to invade the middle ear and mastoid, becomes second infected, it accumulates keratin and the infection, and also has some pressure and enzymatic effect on the surrounding bone, some inflammatory mediators that will make it bone erosive disease. To erode the bones, bone of what? Facial canal, ossicles, attic, medial fossa tegmen, lateral subsacral canal, all this could be eroded by the cholesteatoma. The patient presents with, again, the discharge and hearing loss. There's no pain in the uncomplicated case. But if there's complication, there's pain. So the patient with this type of disease, when they develop persistent pain or headache, we have to think of complication. Otherwise, it should only present with hearing loss and discharge. Discharge is here foul smelling and scanty, okay, and it usually continues, but could be also intermittent. If it is minimal and scanty, the patient may tell it is not every day, but it is not related to the common cold. It is due to the sac, infected or not. Here is the other type of perforation. The previous one we call attic perforation, but here it is the posterior superior perforation. You see the aneuromalias, you see the skin inside the perforation. This skin growing in the middle ear. You cannot clear this in the clinic. يعني مش ممكن اشفطه كده وانضفه واحس ان الودن بقت كده. ده ما فيش كوليستاتوم. Look at this. This without cholesteatoma. I mean, it is clear of skin. You cannot do this. Remove the skin in the clinic until you see this view. No. It is a surgery. Surgery here is not laryngoplasty. It is bigger than this. We open from behind. We do mastectomy. And also tympanoplasty. So the operation is called tympanomastectomy. Tympanomastectomy. It is to remove the sac. You come from behind until you reach this sac. Come from behind the ear until you reach this area. Remove this sac completely. And they do grafting, but also do reconstruction of the middle ear. So we call it tympanomastectomy because it is more than tympanoplasty. It is mastectomy plus reconstruction of hearing. This is the operation being done now to remove the sac and to care for the hearing. Because previously they used to call it radical mastectomy. Complication of the first media, you already presented a seminar about this. But here I put this complication, acute mastocytosis. In a child during an attack of acute media, he may continue to have discharge from the ear, still ill, with fever, and then there's swelling behind the ear. The swelling is due to infection of the mastoid air cells. There is disruption of the bony partition, circulation of pus, tension, the affected way to the cortex. Now there's perforation in the cortex. Subcutaneous abscess, subcutaneous abscess may be fistula later on if you leave this child without treatment. But it's called acute mastocytosis, so the patient will have fever and the discharge, mucopurulent discharge, a lot of discharge. and this is swelling. The swelling typically displays the auricle outward and downward. Outward and downward. So from a distance you can tell. And I can tell it is a case of acute mastitis. Early cases with pain and fever and a lot of discharge may be cured with antibiotic, parenteral antibiotic. But late cases need drainage like this. So you have to open and drain. The operation here is called cortical mastectomy. Cortical. So it is a simple form of mastectomy, just to open, incision, and to remove the tissue, to elevate or extract the tissues and expose the bone and remove the pus, drain the mastoid, with a drain, give antibiotics. It's called the cortical mastectomy. The cortex is the thin or the bony cortex, the shell of bone. The shell of bone normally here, and there are cells here. So you remove the shell of bone to expose the cells, clear them, with a drain, give antibiotics. Some tumors in the middle ear, one of them, glomus tumor, from the paraganglia. Patient presents typically with pulsatile tinnitus. And due to this vascular tumor, very vascular tumor. And they have hearing loss. If the tumor is early, you can see a red mass behind the tympanic membrane. You see the tympanic membrane and you feel that there's something red behind it. It's vascular mass. You can make it blanch by single pneumatic endoscopy or by pressure of the carotid, so it will blanch. It's very vascular mass. Later on, they have other symptoms. Maybe sensorineural hearing loss, these affections of the inner ear. Maybe facial paralysis. Maybe paralysis of the last 4 cranial nerves and the hypoglossal. So, yeah. So they have this. If this late case, again, the perforation of the tympanic membrane with bleeding polyp in the ear, very vascular polyp, we have bleeding per ear. So this is the scenario of the patient with glomus tumor. Typically, the tumor arises from below upwards. We call it sign rise appearance. Because it arises from the jugular bulb. It is called then glomus jugulare. But if it is from the pharyngeal branches in the middle ear, sometimes we call it glomus tympanicum. So it depends on which branch of nerve it arises from. If it is from the dome of the jugular bulb, the floor, it will be rising from below. It is very clear to be glomus tumor. Treatment, you need to do pre-operative embolization to decrease the vascularity, and you do surgery for this patient, especially if he's healthy man or healthy patient. Surgery is what's called infratemporal approach, infratemporal fossa approach. Infratemporal fossa approach, again through the mastoid, but with the section of facial nerve, with exposure of the neck vessels, the carotid and the jugular. You need to control these big vessels, صح؟ وإلا يعني يحصل bleeding. You cannot, يعني you should put temporary ligature or يعني some way you immediately control bleeding if there is accident. So you control the vessel in the neck, the carotid and the jugular, you expose the facial nerve, you do a sort of mastectomy again. So it is called then infratemporal fossa approach. The other benign tumor, the vestibular schwannoma. It arises from the vestibular nerve, especially the superior vestibular. The patient typically presents with tinnitus. It is not versatile. In this patient, there is tinnitus, there is hearing loss, maybe some mild dizziness, but the main symptom is tinnitus and hearing loss on one side. The other side is normal. So in this case, you have to investigate. You have to think of rectocochlear pathology. It is essentially hearing loss in the patient 40 old without any explanation of this hearing loss. So why this the case? You can do EBR. You see this intraoral latency difference. So you know that this could be a cochlear lesion, and then you go for MRI with contrast. It's a very brilliant tumor in the MRI. It's a very, very big tumor, compressing the brainstem, this is the cerebellum. This is the intracanalicular part, this part. So it is centered on the canal. It could not be meningioma, for example. It could not be meningioma. It is acoustic or vestibular schwannoma. So the approach for this tumor, after diagnosis, again, you have to remove it because it is a benign tumor, yes, but it may kill the patient by the size itself. But it is an intracranial tumor, so you have to remove it. How to remove it? We have different approaches. So one approach is from posterior. You have to extract the cerebellum and expose the tumor and remove it. One is lateral, but here is the labyrinth. The black color here is a labyrinth. So you sacrifice the hearing in this patient. So this is called translab. One is called middle fossa approach from above. You make a window here, you extract the temporal lobe, it's what the meatus, you dissect it between the cochlea and the vestibule. If you remember the CT of the bone I showed you, there's a cochlea in front and the vestibule behind. So you go between them and dissect to expose the canal and then remove the tube. Which approach you choose depending on the hearing level. If the hearing level is good, you go from behind. Because you don't like to sacrifice the cochlea or the hearing. If the hearing level is very bad, non-serviceable hearing, then يعني مش هيفيدنا في حاجة, you go to translab instead. So this middle fossa approach is not very common, but it's only used for intracanalicular tumors. It should be very small, and the hearing is very good. Okay, so we have these three approaches for acoustic neuron. This is another tumor. It is smaller, but it's very brilliant again with this intracanalicular part and this part and the CB angle, but without evidence of compression on the cerebellum or brainstem. It's called ice cream cone.
Ice cream.
Ice cream.
ايس كريم كون, يعني ايس كريم كون يعني زي الكون بتاع الايس كريم, له يعني حاجه كبيره كده وكون بتاع
بسكويت.
طيب كذلك تيست ويسبرين ذا glasses. This from Dr. Walid lecture. You need sometimes to test the balance of the patient. He has a history of Meniere disease or maybe vestibular neuritis or evidence of previous labyrinthitis. So we'd like to assess the balance function of this patient. There's a lot of tests could be done, but the commonest is Kaladic test. We have what's called ENG, electronystagmography. It is a battery of tests for balance. The main thing we monitor is the nystagmus, but this is monitored by the device itself, by the computer. So electronystagmography. So we monitor the nystagmus during this group of tests. The most important one is Kaladic test. Kaladic test, you irrigate the ear with cold and warm solution. Cold and warm is 7 degrees up, 7 degrees below. Suppose the patient was previous labyrinthitis or previous vestibular neuritis. What do you expect in the Kaladic response on this side? To be low or high?
High.
The Kaladic response here, you stimulate the labyrinth after labyrinthitis, after vestibular neuritis. You expect the response to be as equal at this side?
No.
Or low?
Low.
No. We call it a canal paresis. Canal paresis or canal hypofunction. So this is what I expect. If you get the ear with cold and warm water here on this side, which is disease side, you expect the response to be weak. So the nystagmus will be little in time and the amplitude. In both sides, it is a bilateral movement, but when you irrigate this, you stimulate this labyrinth. It is very weak labyrinth. It will not give the big amplitude and the normal time. So the time and amplitude will tell you that this side is hypofunction. When you go to this side, you get the normal response. So this is hypofunction on this side. Okay? So you do this Kaladic test. If this hypofunction, the time and amplitude of the nystagmus will be much diminished, even zero. Sometimes you get 0 caloric. If this labs is dead, you get here, there's nothing in the eye. You get here, very good response. Okay? You know, after destruction of one labyrinth, the other side will take over and you become responsible for the balance of the patient. So you expect this to be normal if there is a dead labyrinth on this side. The mnemonics you remember is cows. Cold opposite, one the same. Cold opposite, one the same. So the direction of the nystagmus in cold stimulus is opposite to the opposite side. يعني أنا بعمل irrigation لدايت عايزين left beating nystagmus. ده لو بعمل بالكولد. بعمل بالورم on the right side هيبقى right beating. But it's called It's called cows. The response of the nystagmus will be left beating, right beating, depending on the stimulus you do. Cold will be opposite to the ear. So I get the right, it will give left beating nystagmus. I get the right with warm, it will give right beating nystagmus. So this is something you remember if you read it. This is a very famous test in our specialty, the Dix-Ulvite maneuver. For which disease? For the commonest cause of vertigo, the benign position of paroxysmal vertigo. The pathology is where in the canals, especially the posterior one. So the patient will have problem while looking up, while rolling in bed. It is for a few minutes. It is a fatigable vertigo nystagmus. fatigable يعني ايه؟ يعني العين لو عملت كذا مرة هيروح. لو عملت كذا مرة العين نفسه هيقوم يمشي خلاص. الأول مش عارف يتحرك بعد كده ايه؟ خلاص راح. يقول لك حصلت مرة مرتين بعد كده اتحركت وخرجت الشغل يبقى كده. تاني يوم بيتكرر تاني. The otoconia, free otoconia in the canal are stagnant somewhere. Once you move the head, they will stimulate the canal. But the repeated stimulation will fatigue the canal, this crystal. So it is fatigable and stagnant. So what you do, the patient in the back, in the bed, and then on his back, and then the head is overhanging. يعني لغاية الحرف السرير اهو وهي ايه beyond it. So it is overhanging on the edge of the table with and the head turned to one side, and it keeps her eyes open so that you monitor the nystagmus. Once you put the patient rabbit to this position, if she has this disease, you will see this nystagmus. It has some latency first, and then it will continue for 1 minute and then disappear. If you repeat it, it's fatigable.
Purely horizontal.
Usually it is not purely horizontal. It is vertical with some rotary component. Because it's a posterior canal. The posterior canal is responsible for the vertical, it is not oriented horizontally like this. So moving the head in this direction will stimulate the posterior and the posterior and the superior canal. But moving it like this is the horizontal canal. So it is vertical nystagmus with some rotary component. Okay. Shifting to the nose, we have the anatomy. Spend a lot of time in the left and middle wall. It's important because it is the site of the drainage of the sinus. So, inferior meatus, we don't have sinuses. This, middle meatus, we have 3 main sinuses: frontal, maxillary, and anterior small L sinus. There are some names you may need to remember. The answered process, this little sickle-shaped bone hiding the openings of the frontal maxillary. If I come from this direction in surgery, I will not be able to see anything unless I remove this by anthenectomy. And then I have this semineural hiatus, or hiatus seminularis. Between this cell, it's called the bulla, this moidalis, which is a big small cells, and the uncinate, this hiatus seminularis. And then I see this hiatus seminularis is just a 2-dimensional opening. If I go lateral to it, I am in the infundibulum, a 3-dimensional chamber, small chamber called infundibulum. This infundibulum, I have the opening of the maxilla. Above the frontal recess, continuous infundibulum or opening alone, separately, is frontal recess through which the frontal sinus will drain. As you see, the anterior small cells are near the frontal recess. They are surrounding it, above and below and in front. They may narrow this frontal recess, so you need to take them out to open the frontal recess. This is called Agarnazi cell, and anteroinferior to the frontal recess. If it's big, it will narrow the frontal recess. And then we have the anterior small cells. The biggest one is the bulla. And then superior meatus, we have the posterior small cells. The superior small cells, we have the sphenoid sinus. Examination of the nose.
If you remove uncinate versus
If you remove the uncinate, this is the first step in the scabic sinus surgery. You remove it, the critical piece of bone, critical piece. If you remove it, you simply, by this simple maneuver, simple step in the operation, you widen the drainage of the maxilla in the front first. So you did some favor for the patient. You widen the drainage. And also you expose things to see. So I can see now the maxillary ostium, okay, better than with the uncinate in place. So I remove it because to expose the drainage ostium of the maxillary sinus. Okay? So it is to help the drainage of the frontal and maxillary, and also to complete the steps of the operation. If you like to remove, to drain the maxillary, to wash it, will be much easier if you remove this uncinate. Then examination of the nose, we have the systematic or clinical approach, inspection, palpation. And then we have rhinoscopy. It gives you anterior view of the nose. If the view is limited, you can spray with decongestant to see more posteriorly, more superiorly. You can see the middle meatus. Some disease of the nose, very common, nasal bone fracture, trauma to the nose from one side, from front, fracture the nasal bones. They are thin bones. So you see the deviation, deformity, you see the ecchymosis below the eye swelling. You have to examine the cavity of the nose to see if there's laceration, bleeding, hematoma collection, the fracture of the septum. And then you need to reduce this fracture. If the patient comes late with a lot of edema, you may wait for 5 days, 7 days maximum for the edema to resolve, and then you bring him for reduction. But if he comes very early, you can do immediate reduction. Immediate reduction by, or reduction in general, it is by manual manipulation. If the bone may click back to its site, or its place. Or you use a bone forceps called Wiltshire forceps. You manipulate the fragments, you disengage them, you return them to their normal position.
Blindly, doctor.
Eh?
Blindly, without any.
Yeah. Not blindly, but first you assess the deformity with your eyes. You know, you ask about the direction of trauma. You know that there is division of the bones to one side. So your aim is to bring them to the midline. So you disengage them and return back to the median. Sometimes there's difficulty in reducing these bones if there is fracture of the septum. The septum is fractured and there is overlap of the bone fragment, and whenever there's some spring now, you have to dissect the septum and release this impaction. Then the nose will click back to its position. This is why you should examine the nose to see if there is fracture also of the septum. Just to open the septum and dissect the flaps, limited dissection may be sufficient for the nose to click back to its position. You put a bag and you put some splint to prevent displacement of the fragment again. Nasal septal perforation, a lot of causes for septum to perforate. Main reason is surgery. Submucous resection, SMR. Other reasons is granulomas, sniffing of cocaine, maybe antibiotic without a reason. The idea is to know that this should be avoided. Maybe asymptomatic, it may be symptomatic with crustation, some sensory obstruction, some bleeding. You give some symptomatic management in form of irrigation of douches, or you give some lubricant. Surgery could be done, but is very low success rate. Septal abscess, or septal hematoma first. Blood flowing to the nose, collection of blood within the septum. The cartilage will necrose if you don't drain. So you have to drain it. Otherwise, the cartilage will necrose, the support will be lost, or it will be infected, causing a abscess. Again, you drain the abscess, you put some backing to prevent recollection. You may need to go back and do some sort of rhinoplasty for this lack of support and the depression or saddling later on.
How can I differentiate between the hematoma and abscess?
It's a good question. It is by the history, by the pain, by the fever, by aspiration. So you get this patient with sense of trauma 2, 3, 4 days back. He has fever now. He's very tender nose. Okay, and then you aspirate. You get this frank pus. The swelling is fluctuant. Fluctuant يعني very very fluctuant. This abscess. Fluctuant يعني يعني تدوس من الناحية دي it will bulge from the other side. I think fluctuation في swellings in the skin. So it will be very fluctuant with this pus. Epistaxis. Epistaxis is 2 categories. Children, little area and less blood supply, you know it. And the adult or elderly patients with hypertension with posterior bleeding more than anterior. Branch of the sphenopalatine and the internal axillary artery. You stop this bleeding after, you need to localize the bleeder if you can. If you can do cautery. First you apply manual pressure. This may stop the bleeding from little area. This here, under my finger. The soft part of the nose, not the bone. And then you can do cautery of silver nitrate or electric cautery. If you cannot see the bleeder and the bleeding is severe, you need to stop it immediately by putting a pack. Pack could be done with a balloon double balloon. This will engage in the coena, and then you inflate the other one to exert pressure on the bladder to stop the bleeding by this double balloon, Steck's balloon. If you don't have it, you can use the conventional pack with gauze and Vaseline and antibiotic ointment, or you can use Merocel. Merocel is compressed sponge with the stent, with if you add some saline or water, it will distend and fill the nasal cavity. Otherwise, we need to do sometimes posterior packing if the bleeding is from the nasopharynx itself, or if you don't have this balloon, you may need to plug the coena by this pack. You guide it to the mouth to fit in the nasopharynx and fill it, and also plug the coena, and then you apply anterior nasal pack also. So you stop anterior and posterior bleeding by this posterior nasal pack and anterior nasal pack. So in this slide, photo, I have to see again nasal pack here, so that it will plug the nose and stop the bleeding. Also, this we use endoscopic control. If you can collect the bleeder with a scope, it's better. You have the facilities, you have this suction cautery probe, so you clear the field and you identify the bleeder, you stop it by cautery. Sometimes we dissect endoscopic control again to put a clip on the branches of this sternopalatal artery. Theta deviation that you see here, this patient may have trauma since birth, or sometime early childhood trauma, causing some visible deformity, some deviation of the pyramid, and some also bulging of the cartilage in one nostril. There's nasal obstruction, maybe other symptoms, and he comes with this nasal obstruction. We have two operations, this SMR and septoplasty. Which one you choose? Septoplasty is more conservative without chance for depression or other complications. Sinusitis, we might finally cover this. So we have acute sinusitis, we have chronic sinusitis. Sinusitis may start viral by viral infection, and then the virus will pave the way for bacterial infection, the respiratory pathogens, like in the ear. And then the patient will have more symptoms, some fever, some body aches, some purulent or mucopurulent discharge. Like here, you get this, and then it develops the nasal obstruction, nasal discharge. So the maxillary and the spine are involved in this patient. From the history, it starts acutely after this common cold. Then you need to give treatment. This we can confirm it by plain X-ray or CT. There are some protocols to do CT for acute sinusitis also. And then you give antibiotics. Which antibiotic you choose? Amoxicillin, gimelic acid, because you expect some resistance. The second is cephalosporin, recent macrolides, quinolones, if the patient has some history of recent antibiotic use. So I can use quinolones. Okay? If he has recent, this one, I received an antibiotic course 2 weeks back. Now he's still having the symptoms, or even mucopurulent discharge, or some facial pressure, some headache, postnasal hyposmia, is sick. You need to give this quinolone then. But don't start with quinolone for every patient with sinusitis. There should be some limitation of use of quinolones in acute sinusitis.
Duration.
Duration of an acute, you give 7 to 10 days. But in chronic, you need to give longer course. Chronic sinusitis, the patient has probably more than 3 months. To label it as chronic, it should be built for 3 months. He has not very severe symptoms, but continuous discharge, hyposmia, facial pressure, headache, frequent and repeated headache. And you examine, you see the evidence of infection, drainage from the sinuses, congestion of the mucosa, endoscopy and CT. So CT will show you the evidence of infection. So you see you comment on what's called osteometal complex, the area that we discussed, the middle meatus, the hiatus terminalis, the bulla ethmoidalis, the mandibular, the frontal recess. So this is the obstructive. Look at the drainage of the maxilla, blood. So there's blockage of the ossification of osteometal complex area. We have to comment the sinuses. This is totally ossified, and this is the marked thickening of the mucosa with obstruction of the drainage of the maxilla. This patient, if he does not have polyps, we mean it is made medically. So chronic sinusitis should be treated medically first by long course of antibiotics, we add steroids, mucolytics, anti-inflammatory, anti-allergic if there's evidence of allergy. And then if there is failure, then you go for surgery. But polyps, sinusitis with polyps may be indication for surgery. Sinusitis with polyps. Or sinusitis with evidence of narrowing of the ostomy complex. Then you need to improve the drainage and ventilation of the sinuses. But I can tell that most cases of chronic sinusitis could be treated medically without surgery. Most cases. You have even to modify the habits of the patient. Smoking. واحد مدخن على طول وعنده sinusitis. طب ما توقف توكيل قوي. تمام؟ يعني صعب ان احنا نعمل له عمليه وهو مدخن وشارك في التدخين كمان. Polyps. We have ethmoidal polyps. The most common type is ethmoidal polyps because the ethmoidal is group of cells. Labyrinth, we call it ethmoid labyrinth. So the chance for polyp formation is greater than the ethmoid. But sometimes the polyp arises from the maxillary sinus, as here. It's called anterocranial polyp. So it arises from the maxillary sinus on one side usually. We fill the sinus, gets outside the sinus, so it's a natural ostia, to the nose, and then to the quena, and then to the nasopharynx, maybe visible in the oropharynx. So we call it a antero with the maxillary sinus, quenal polyp. The patient will have evidence of discharge, obstruction, hyposmia. You see the polyp in the nose and also maybe in the nasopharynx if neglected. You need to remove this polyp. Treatment started here. You need to remove the intrasinus part, the nasal part, and the nasopharyngeal part. So it is triple or 3 parts. You may deliver it through the nose, or sometimes we deliver it through the mouth. If it's too big, you cannot pull this mass from the nasopharynx to the nose, you pull it from the mouth. But this rare polyp. The commonest is this type of polyps is ethmoidal polyps. So they are multiple, grape-like, simply. The patient will have obstruction, discharge, hyposmia or anosmia, snoring, mouth breathing,